This is Acute and Chronic Pain, Module 9. Here's a breakdown of the final exam. It's 100 questions. Approximately 30 to 35% is Modules 9 and 10, 40 to 50% from Modules 1 to 7, and 20 to 25% from Module 8. Here's your objectives. You need to describe the physiological process involved in the maintenance and restoration of health and wellness, evaluate the process of pain management through the use of clinical judgment and nursing process, explain the difference between personal and professional identity in regards to caring for a patient that needs pain management, and utilize various forms of technology and professional references to support the care of the patient. Reviewing the pathophysiology, we have the two systems. We have the peripheral nervous system, which is paired sensory and motor spinal nerves of the peripheral nervous system, and then the central nervous system is all sensory info except for the olfactory, um, passes through the thalamus. Classic definition of pain is an unpleasant feeling that is conveyed to the brain by sensory neurons. The patient report is the most reliable indicator of pain. There is no way to objectively measure pain, so we have to go by what the patient is reporting. We have the physiological response to pain. You're going to see an increased heart rate and stroke volume, increased blood pressure, delayed blood flow to the viscera and skin, which can cause delayed wound healing time, disturbance in endocrine and gastrointestinal functions, increased blood viscosity, which puts them at a risk for deep vein thrombosis. Unrelieved pain can prolong stress response, and it produces a cascade of harmful effects in all body systems. Stress response causes endocrine system to release excessive amounts of hormones such as cortisol, catecholamines, and glucagon. Insulin and testosterone levels decrease. There's an increased endocrine activity in turn, which initiates a number of metabolic processes, in particular accelerated carbs, proteins, and fat destruction, which can result in loss of weight, tachycardia, increased respiratory rate, shock, and then even death. Immune system is also affected by pain, as demonstrated by research showing a link between unrelieved pain and a higher incidence of nosocomial infections and an increased tumor growth. We have influences on pain response, sociocultural influences, express or exaggerate their distress, could be punishment for sins, an imbalance in the environment. Regards to age, children learn how to respond to pain from their parents. Could be chronic pain, which is common for elderly, and could be mild age-related increase in pain threshold with aging. You also have gender. Most cultures, men, boys, minimize outward expression of pain, where girls, women feel it's appropriate to express pain. Women lower threshold to pain and have varied responses to opioids. You have behavioral signs of pain, could be facial expressions and culturally determined restlessness, change in activity, crying, fear, anxiety, anger, sleep disturbances, depression. Pain threshold is considered the point at which a stimulus causes pain, and it varies. Pain tolerance is the maximum pain level a person can withstand. Categories of pain duration. You have acute. This is from illness, injury, or surgery, and it lasts less than 6 months. It alerts you to injury. Acute is a protective alarm type system. You have chronic, which is 6 months or longer, more than 12 weeks. Persistent firing within nervous system after initial injury is healed. The combination is just acute and chronic. Types of pains. Nociceptive pain occurs when pain impulse is processed normally over intact nerves. Your somatic pain is nociceptive pain that originates from the bone, joints, muscles, skin, or connective tissue. This is associated with rheumatoid arthritis, osteomyelitis, fractures. Then you have visceral pain, which is pain from the organs or gastrointestinal tract, and this usually refers to any large organ with a body cavity. So it could be appendicitis, cardiovascular disease, pancreatic inflammation. Referred pain is a transfer of visceral and somatic pain through the autonomic nervous system to an area distant from point of origin. Like in an MI, you have pain in your left arm, neck area. Neuropathic pain is a result from injury to a nerve. And neural pain can be like a spasm like pain, sharp shooting pain. You have breakthrough pain, transitory increase in pain that occurs in addition to persistent pain. It occurs with cancer pain and chronic pain syndromes. And then you have the intractable pain, which is resistant to treatment. Cancer pain is a type of an example. Responses to persistence of acute pain. You can have poor quality of sleep, about 86%, mood, mental health, difficulty concentrating, about 70%. You have a sense of lost control, increased stress, depression, and depression because pain causes a decrease in the serotonin production, and then depression causes a decrease in the serotonin reuptake. Decreased serotonin causes pain to be more noticeable. Long-term effects for chronic pain: low energy level, weight gains common, cortisol levels chronically are raised, sedentary lifestyle due to the pain, and they also can have an increased incidence of diabetes mellitus. Long-term effects: cardiovascular changes, weakened immune system, and their quality of life decreases. Social life interaction, just there is none most of the time. You have elements of a pain assessment. Patient self-reported pain: location, intensity, quality, onset, duration, alleviating or relieving factors, effect of pain on quality of life and functional status, and the comfort and function goal. We have the 5 C's of pain treatment. It's comprehensive assessment, consistent use of assessment tools, continuous reassessment, a customized plan of care, and collaborative or multidisciplinary approach using both analgesic medications and non-pharmacological interventions. We have the different pain assessment tools or scales. You have the numerical, which we use between 0 and 10, the Wand-Baker faces scale, which is more pediatric patients or patients that cannot read or language. Verbal graphic rating scales: no pain to worst possible pain. Pain aid scale: rate breathing, negative vocalization, facial expression, body language, and comfort. This is used more with patients with dementia or confusion that aren't able to actually give you a realistic rating on their own. Pain assessment: how does the nurse conduct a pain assessment? How does the nurse assess for breakthrough pain? What are common challenges with pain assessment? So what you want to be looking at, pain reassessment, we know it's giving a medication and then reassessing them. How do you assess for breakthrough pain? What are common challenges? We do know that when then pain usually comes on with activity or during a procedure like a dressing change. So we know that we're going to be giving them medication before they go to therapy or before they do a dressing change, and then we're going to reassess afterwards and make sure that that pain medication worked. The clinical management of hierarchy of pain measures: obtain patient self-report, consider the patient condition or exposure to painful procedures, observe for their behavioral signs, evaluate psychological indicators, and conduct an analgesic trial. Non-opioid analgesics are like your NSAIDs, non-NSAIDs like acetaminophen, NSAIDs like ketorolac or Toradol, ibuprofen, naproxen. These help with fever and pain, but do not help with inflammation. and I'm talking about the non-NSAIDs, where our NSAIDs will reduce fever, pain, decrease inflammation, and then it increases platelet aggregation, which can put people at a risk for GI bleeds. So we have to remember NSAIDs are medications. They're contradicted with other blood thinners. The different type are transdermal, so your morphine, fentanyl patches. PO'd could be your opioid only, like a tramadol, oxycodone, hydrocodone, or combination Percocet, Vicodin. Or you can have the OxyContin, which is the extended release. In IVs, we could do morphine, hydromorphone, or Dilaudid. Um, Opioids can be effective in acute and nociceptive pain, but not very helpful in pure and neuropathic pain. These drugs can produce an emotional high, which can cause patients to sometimes become addicted to them. They can cause major constipation, nausea, vomiting, respiratory depression, and people who have a continuous pain along activating analgesics such as a modified release oral um, morphine, oxycodone, or hydromorphine is used to treat the persistent pain. You have physical dependence in opioids. This is an involuntary altered physical state. You can have an addiction, which is a compulsive disorder in which an individual becomes preoccupied with obtaining and using it. And a tolerance is when a higher dose of the drug is required to achieve the desired effect. Ad- Adjuvant medications are like your anticonvulsants, so your gabapentin, which is also called Neurontin, your Lyrica. You could do tricyclic antidepressants like amitriptyline, um, which the other side of it also helps with sleep quality. You could do SSRISs. They're less effective at pain, but they can help with the depression. Um, and then muscle relaxants like baclofen or cyclobenzaprine. Sometimes these are added to other analgesics to aid in relieving the neuropathic side of the pain. They can also give sedatives, facilitate sleep. You have the transdermal patch like narcotics, lidoderm, 10%, usually 12 hours on, 12 hours off. Um, Menthol, capsaicin. Non-pharmacological pain relief methods, massage, acupuncture, or acupressure, positioning and body alignment, splinting, transcutaneous electronic neural stimulator like a TENS unit, thermal interventions like heat and cold. You could even have mind-body therapies like self-hypnosis, guided imagery, meditation techniques. Inferred pathology, just know, define and provide examples of the following. So just do that. Lastly, fill out this table, which we have. Just make sure you understand this table and how to link it to pain.